Okay, we're going to go ahead and get started here with the little discussion on ventilation, perfusion, and shock, and how pathophysiology all works together. When we maintain adequate ventilation, we maintain adequate perfusion, we're going to keep our patient out of shock. But should we have issues with breathing, or should we have issues with our blood pressure, patients can go into shock. So we're going to get into this discussion here. And pathophysiology is the study of how disease processes affect the function of the body. And understanding pathophysiology is going to help you recognize changes that the patient is going through due to an illness or an injury. So, that first bullet point talks about how disease processes affect the function of the body, but certainly injuries can affect the processes of the bodies as well. The basic, the cell is the basic building block, if you will, the basic makeup of the body. And the cell is covered by a membrane that protects and selectively allows water and other substances in and out of the cell. Those other substances include things like oxygen, glucose, sodium, potassium, magnesium, chloride, bicarbonate. So a variety of different electrolytes are allowed to move in and out of the cell, as well as hormones like insulin, those sort of things. And within the cell, the mitochondria then convert glucose and other nutrients into energy. And the name of that energy is adenosine triphosphate. It is the fuel for the cell's functions, and without adenosine triphosphate, many of the cells would not function at all. Cells need also a correct balance of water, both inside the cell itself as well as outside. If the cell has too little water inside, it becomes dehydrated and dies. If the cell has too much water inside, the basic function of the cell is interrupted. And water in the body also affects the levels of sodium, potassium, magnesium, chloride, and bicarbonate, which the sodium, potassium, and calcium are extremely important to cell function, particularly electrical cells like the brain, the heart, where those electrolytes are very important for muscle contraction and brain function. Glucose is, of course, the main substance the cell needs in order to make energy. And glucose cannot get into the cell by itself. Glucose is a little larger molecule. It needs some help being transported from the blood into the cell. And insulin is the hormone that your pancreas secretes that allows sugar to move from the bloodstream into the cell so the cell can make energy with it. Certainly without enough sugar, the cells won't function properly, and without enough insulin, as in the case of diabetes, the sugar won't be able to go into the cell to make the energy as well. This whole production of energy thing, this whole production of adenosine triphosphate occurs when glucose combines with oxygen through a very complicated chemical process to make energy for the cell. The glucose, one glucose molecule and one oxygen molecule will make 32 packets of adenosine triphosphate. So 32 little energy packets, or little energy supplies, that the cell can use to help carry out its function. When we have no oxygen available, as in the case of low oxygen levels in the blood, which we call hypoxia, when we have no oxygen available, the cell will still produce energy. Glucose will combine with fat, and as the body metabolizes the fat, a very small amount of energy is produced. In fact, only 2 adenosine triphosphate packets, and then a lot of pyruvic acid. Pyruvic acid also breaks down into what's called lactic acid, which can lead to lactic acidosis and can change the pH in your body, which will affect all your cells' ability to function. Metabolism without oxygen is called anaerobic metabolism. It's not very effective in making energy. It produces large amounts of lactic acid, which, if left unchecked or untreated, will lead to shock. Now, there are many diseases that alter the permeability of that membrane. Remember, I said earlier that the cell is surrounded by a membrane that allows certain things to come in and come out. Some other things that float around in the blood and in the interstitial tissue and around the cells aren't allowed to come in. As an example, a virus. How a virus lives, it requires a host. It requires a way to feed itself. And a virus cannot get into a cell, so it latches itself on the outside of the cell, where it then robs the cell of its energy. Now, if your cell membrane breaks down and there's a change in permeability, that may allow substances into the cell that should not be there. And these substances can interfere with the regulation of water. What they're referring to here is during anaerobic metabolism, metabolism without oxygen, when all that lactic acid is being produced, lactic acid destroys the permeability of the cell membrane, and it allows sodium to rush into the cell. And as sodium rushes into the cell, it brings with it water. And the cell becomes overhydrated. It fills way full of water to a point where it bursts and dies. So anaerobic metabolism leads to cellular death. A collection of tissue are made up of cells. Specialized tissue makes up an organ. So liver cells make up liver tissue. Liver tissue makes up the liver. A collection of organs is called an organism. So we're an organism. We're made up of specialized organs that allow us to function and carry out our daily life. If the cells die, the tissue dies. If the tissue dies, the organ dies. And if the organ dies, the organism dies. And this is the natural progression of shock. So as an EMT, we have to be able to recognize that our patient is in shock, and if there's something we can do about it, quickly do those things that lessen the amount of cell death that occurs from anaerobic metabolism. Now, the cardiopulmonary system, which makes up the respiratory system and the cardiovascular system, they work together in maintaining aerobic metabolism. The lungs bring oxygen into the body. The cardiovascular system, the heart and the blood vessels, distribute that oxygen to the cells, but also then from the cells remove those waste products to be filtered through the kidneys, through the liver, and removed from the body and made harmless. So any breakdown in the respiratory system that affects the ability of oxygen to get into your bloodstream, or any breakdown of the cardiovascular system where the heart doesn't work as a pump, or the vessels are fully dilated, or there's not enough volume, or there's not enough blood in the cardiovascular system, will lead to shock as well. Your airway is made up of, when we look at the breathing tubes as an example, the lower airway begins at the larynx. So the voice box, below the voice box is the trachea. And the trachea has rigid cartilage bands around it that keeps it distended and open. And the trachea travels down, and at the level of the carina divides into two main stem bronchi. So the left main stem bronchus and the right main stem bronchus continue on to the left lung and the right lung. The bronchi get smaller and become secondary bronchi, and even smaller and become tertiary bronchi, and then even smaller and become terminal bronchioles. And the bronchioles, at the end of those bronchioles, are all these air sacs called alveoli. And there are about 700 million alveoli at the end of these terminal bronchioles. And the air sacs are surrounded by capillaries. And the capillaries then bring oxygen. I should say it this way. The lung, those air sacs, bring oxygen to those capillaries, where oxygen, through a process known as diffusion, moves from the capillaries, or moves from the alveoli into the capillaries. And then the carbon dioxide that is in those capillaries coming from the body moves from the capillaries into the alveoli, and when you exhale, you get rid of all that carbon dioxide. When you inhale, you bring that fresh oxygenated blood to those alveoli, where that freshly oxygenated blood makes its way into the capillaries, and the carbon dioxide makes its way into the alveoli. They trade places, and you exhale and get rid of that carbon dioxide. Now, this process occurs all the time. And when we look at all those terminal bronchioles and those 700 million air sacs, not all of those alveoli beds covered with capillaries are exchanging gas every single time you breathe. The more you work, the harder you exert yourself, the deeper and faster you breathe in order to fill all those capillaries with oxygen so that gas exchange can take place. Now, anything that puts a distance between the alveoli and those capillaries is going to affect oxygen getting into the blood and carbon dioxide getting out of the blood. So anything like fluid in the alveoli, if those air sacs have mucus, or if those air sacs have pulmonary edema, as we'll learn in different conditions, oxygen exchange is not going to take place. Anything that obstructs the blood flow through those capillaries, gas exchange is not going to take place, like a pulmonary embolus or a blood clot in the lung itself. When we look at respiration, ventilation, oxygenation, all those words we use to describe breathing, it begins with the airway. And you have to have a patent airway in order for the system to function. The upper airway is the nose, the mouth, the throat, and all the way down to the larynx. And the lower airway is the larynx on down. So the upper airway obstructions are pretty common. most often in an unresponsive person who's lying flat on their back, particularly an infant or a child, then tongue is going to be the most common airway obstruction. But airway obstruction can also be caused by foreign bodies. They may choke on something. They may be caused by infection or swelling of the airway, or they may be caused by trauma to the airway itself. The lungs are considered part of the lower airway, and we just had described briefly a bit about the airways, the bronchi, the bronchioles, the terminal bronchioles, and the alveoli, and how gas exchange takes place as the capillaries wrap themselves around the alveoli. But when we talk about the lungs, some terms that we need to be somewhat familiar with include tidal volume. Tidal volume is the amount of air that a person moves in and out during one breath. So tidal volume can be measured, and in most people, anywhere between 300 milliliters and 500 milliliters would be considered enough air to make their chest rise. So when you took basic life support and you became CPR certified, you know that when you give ventilations, that you give them just enough to make their chest rise. And as soon as their chest rises, that is an adequate tidal volume. So the same holds true when you're doing an assessment of how effective the patient's own breathing is. If their chest is rising and falling, and you can see that rise visibly, then you know that they have adequate tidal volume, that they're moving enough air. What's of concern as well is a term called minute volume. Now, minute volume is the amount of air moved in and out of the lungs over 1 minute. Let's say that I have a tidal volume of 500 milliliters and I'm breathing 10 times a minute at rest. That's 5,000 milliliters of air. That would be my minute volume. That would be the amount of air I need in a minute to stay alive. So we have to consider minute volume as well. So when we're looking at the effectiveness of breathing, we look for chest rise and fall, but we also look at the respiratory rate. Is it adequate enough in order to give us good minute volume? Now, any change in tidal volume or any change in respiratory rate is going to reduce that minute volume and not supply enough air to keep that patient alive. Now, respiratory dysfunction occurs anytime something interferes with minute volume. So anytime you've got a condition, whether it be pneumonia, a foreign body airway obstruction, a pulmonary embolus, a hole in the chest, a spinal cord injury that affects breathing, anything that causes the respiratory system not to work as designed may lead to an interference in minute volume and a potential respiratory distress that may lead to respiratory arrest and, of course, if untreated, cardiac arrest. Respirations are controlled by the brain, and the part of the brain that controls breathing is in the medulla oblongata, or the brain stem. So within the brain stem is a part of there is what we call chemoreceptors and baroreceptors. Chemoreceptors, think of those as little dipsticks. They're constantly looking at the blood and analyzing the pH, analyzing the amount of oxygen in the blood, analyzing the amount of CO2 in the blood, analyzing the amount of pressure in the system as well. And based on the feedback that those chemoreceptors give the brainstem, determines whether or not you increase or slow your breathing down. So if the chemoreceptors in the medulla oblongata are getting the message that there's too much CO2 in the blood, the level is too high, then the respiratory center of the medulla oblongata will send a message to the muscles in the chest telling them to breathe deeper and faster. And by breathing deeper and faster, you're able to blow off some of that CO2 that's accumulating. So any event that impacts the function of the medulla can affect breathing as well. So infections like encephalitis, drugs like heroin, toxins like carbon monoxide, and head trauma with swelling of the brain may lead to a problem with breathing as well. If the wall of the thorax is compromised, in other words, the ribs break and the broken bones puncture the lung, then the patient may not be able to take as big a breath. And if they can't take a big breath, they're not going to be able to move enough minute volume. And again, the importance of minute volume, if you don't move enough minute volume, you don't move enough air to stay alive. Now, in a person who has this fractured rib that punctures the lung, air or blood then will accumulate in the chest and compromise your breathing as well. Trauma or medical problems can compromise the ability of the alveoli to exchange gas. And, here certainly they're talking about medical problems like asthma, chronic obstructive pulmonary disease, those sort of things, and then trauma to the chest wall itself, or trauma to the lung itself, as in the case of a pulmonary contusion or a big bruise of the lung that you might see under those broken ribs. The other thing to keep in mind about respiratory dysfunction is that if I'm not breathing adequately, then less oxygen is getting into my bloodstream, which will cause me to be hypoxic. But as importantly, less carbon dioxide is getting out of the system, and that's allowed to accumulate in high concentrations, and that's called hypercapnia. Now, in an attempt to compensate for these problems or dysfunction of the respiratory system, the chemoreceptors will tell you either to breathe deeper or faster, or a combination of both, or to breathe slower and shallower, depending on whether or not they need to get rid of these oxygen and carbon dioxide, or whether they need to eliminate some of that stuff. Now, also in this mix of oxygenation and ventilation and is blood. Certainly without blood, we would have no way to carry oxygen to our tissues. And there are 4 parts of the blood. There's plasma, which is the transporting medium. It makes up over 50% of the blood by volume. And then we have red cells. And red cells, there are 5 different types of red blood cells. We have red cells. And red cells contain an iron-containing molecule called hemoglobin on the red cell, and hemoglobin is responsible for carrying oxygen. So oxygen is attracted to hemoglobin. People who don't have enough hemoglobin, who don't have enough red cells, maybe because of their body isn't producing it as fast as they're dying, the red cells are dying, or they've lost blood. But anybody with an inadequate amount of red blood cells is said to be anemic. Now, white blood cells, there are 5 different types of white blood cells, and white blood cells fight infection. And depending on what types of white cells are in your system when you measure those blood count, will determine in what stage of the infection you're in. Some are more prevalent in the first stages of an infection, where others are more prevalent on the back end of the infection. Platelets are responsible for helping you form clots. Platelets have very irregular fingers. They do have a tendency that when they get together to stick, and help form this base for rich red fibrin to weave through in order to form a clot. Now, plasma oncotic pressure deals with the proteins in the plasma that attract water away from or around the cells and pulls that water into the bloodstream. So the higher the oncotic pressure of plasma, the more water it will pull from the cell into the bloodstream. Hydrostatic pressure pushes the water out of the blood vessels and towards the cell. Any problems with these proteins, either the plasma proteins, any problem with those can lead to either too much water coming out of the cells and going into the bloodstream, or too much water moving into the cell, causing the cell to swell and burst. Without enough blood, oxygen and carbon dioxide cannot be properly moved around. So patients who bleed are going to lead to shock. Patients who are dehydrated, especially significantly dehydrated, can have shock. A patient who's anemic can have shock, and patients who are in liver failure can go into shock, as well as kidney failure. You might as well just say multiple organ dysfunction syndrome, or MODS, which would be kidney failure, liver failure, heart failure. All those sort of things certainly can lead to shock and or death in a patient. Now you've got arteries and you've got veins. Arteries carry freshly oxygenated blood to all parts of the body, with the major artery coming right out of the top of the heart, known as the aorta. And then veins bring blood back to the heart from the body. Veins have one-way valves in them to prevent the blood from flowing backwards when the heart pauses, to allow the ventricles to fill. Both veins and arteries can dilate or constrict in order to raise the pressure in the system. Now, the blood vessels take oxygenated blood from the lungs, from the heart to the capillaries. So the right side of the heart receives blood from the inferior and superior vena cava, the two large veins in your body. And that unoxygenated blood gets pumped through the pulmonary arteries, the only place in the body where arteries carry unoxygenated blood. So the right side of the heart pumps blood, unoxygenated blood, to the lungs, where it picks up oxygen and returns oxygen-rich through the pulmonary veins, the only place in the body where veins carry freshly oxygenated blood. And that blood then from the lungs dumps into the left atrium and then into the left ventricle, and then out the left ventricle through the aorta to all parts of the body. Now, the gas exchange takes place in the lungs between the cells and the alveoli. Returning blood to the lungs from the heart for gas exchange, where the left ventricle then pumps that blood to all parts of the body, to the capillaries, where oxygen poor blood, cell byproducts, those sort of things are put back into the blood and brought back to the right side of the heart to redo that process all over. Now, prior to the blood getting to the right side of the heart, it is being filtered through the kidneys and through the liver. Now, in order for that to happen, we have to have an adequate pressure. And we measure that with a blood pressure cuff on a patient's arm. And If you've not been taught that yet, you will. But you measure the patient's blood pressure, and if the blood pressure is adequate, you know that the body is moving enough blood to all parts of the body because the pressure is adequate. When the pressure gets low, that's known as shock. And when the pressure gets low, blood is not being moved to all parts of the body, and that is called hypoperfusion or shock. Now, the pressure is controlled by the changing diameter of the blood vessels under normal circumstances. In other words, if I need to raise the pressure in the system because I've lost some volume, let's say through bleeding, then my vessels will constrict. And by making the diameter of the vessel smaller, the pressure in the system is raised. Think of a garden hose. If you look at the end of a garden hose, so let's say it's a 5/8 inch garden hose, you have a 5/8 inch hole there, about a 1/2 inch hole, and water comes out of there at a certain pressure. And when you take your thumb and you put it over the end of the garden hose, making that hole much smaller, then the water pressure increases significantly. And the body does the same thing in order to maintain blood pressure. It selectively vasoconstricts to keep the pressure up in the system. Now, if the pressure gets too high, it'll do just the opposite. It will selectively vasodilate. It'll make those vessels much larger, lowering the pressure in the system. And that's all measured by stretch receptors in the aortic arch and in the brainstem, and they're constantly measuring the pressure in the system and then sending messages to either constrict vessels or dilate vessels depending on the situation. Now, blood vessels can lose their ability to constrict and dilate. This is called loss of motor tone, and it does occur when you have spinal cord injury, perhaps with a meningitis or an encephalitis, an infection of the brain, or an allergic reaction will cause the vessels to fully dilate. Sepsis will cause the vessels to fully dilate. Spinal cord injury, as I had mentioned, will cause vessels to fully dilate. And in those situations, your body's not able to constrict those vessels. So the container gets real big, the pressure drops in the system, and the patient goes into shock and dies unless we can fix what the cause is. So here's an example of a normal blood vessel, and here's an example of a dilated blood vessel. And you can see that on the left, the normal vessel is completely full of blood, where when you dilate the container, there's less blood in there. So there's less pressure in that dilated vessel. I liken it to, the vessels fully dilate. So they double in size, which makes them half as full. And that's going to drop the pressure in the system. Now, when the vessels fully dilate and all that blood pools out here in your arms and legs, it increases capillary permeability. So it increases the capillary membranes, the pressure against them increases to the point where the capillaries begin to leak fluid out of their walls. And this is called third spacing. The fluid isn't in the cell, the fluid isn't in the bloodstream, it's in the tissue somewhere in that third space, and it's known as the interstitial space. So when you have an increase in capillary permeability caused by sepsis, high altitude, anaphylaxis, the vessels will fully dilate as a result of those conditions, and increased capillary permeability because of all the pressure in those capillary beds, and they begin to weep and leak. So I liken this to your bucket's twice as big, so it's half as full, and now it's full of holes. and these patients can go into shock as well. We just need to recognize it early. And then here's a good example of a vessel with an increase in permeability. Now, hypertension is seen when the vessel size narrows. Remember, we had said that when the blood vessels, they will constrict or dilate in response to keeping the pressure up in the system. Now, there are various conditions that are going to lead to abnormal constriction of the vessels that will lead to dangerously high blood pressures, which we call hypertension. So when the vessels fully dilate, get way big, the pressure is going to drop. We call that hypotension. Patient will go into shock. And in the reverse case, where the vessels constrict tightly as a result of a condition or a medication, then the pressure is going to raise very high in the system, which we call hypertension. And hypertension is the #1 cause of stroke and heart attack. Now, the heart itself is a pump that has an average stroke volume of about 70 milliliters of blood per contraction. Stroke volume is, by definition, the amount of blood the left ventricle ejects when it contracts. And cardiac output is a product of blood pressure. And to determine cardiac output, we take stroke volume, the average amount of blood coming out of the left ventricle, times heart rate. And that gives us the amount of blood the heart is putting out in a minute. So cardiac output is a product of stroke volume and heart rate. Stroke volume is based on preload. That's the amount of blood returning to the heart. And you'll learn in your assisted medication discussions that you could assist a patient with administering nitroglycerin. Well, nitroglycerin dilates the system, dilates the blood vessels, causing the pressure to drop in the system. Dilates the vessels, so we have less blood returning to the heart. So drugs like nitroglycerin decrease preload. By decreasing preload, you have less blood coming into the heart. You're going to end up with less blood being ejected every time the heart beats. So you can have a drop in cardiac output and a drop in blood pressure when you give nitroglycerin. Contractility is how hard the heart squeezes, and that really is determined by having the right levels of sodium, potassium, and calcium in your bloodstream, as well as temperature and pH of the blood. Afterload, that's the pressure that the heart has to pump against in order to move blood throughout the system. And afterload, what's important about that term is that think of the diastolic blood pressure. The diastolic pressure is the pressure in the system all the time. That's the pressure that is exerted against the heart, that is exerted against the walls of the vessels all the time. And as that bottom number gets higher, which it normally does as we age, or if we develop hypertension, the disease hypertension, the higher that bottom number gets, the harder the heart has to work as a pump in order to get past that pressure to move blood throughout all parts of the body. So keep that in mind with blood pressure. Now, stroke volume times heart rate, I already told you, is cardiac output, and cardiac output is a major byproduct of blood pressure. Now, a heart that beats really slow or a heart that beats really fast, not allowing time to fill the ventricles, will cause a decrease in stroke volume. You get that decrease in stroke volume, you're going to have a drop in cardiac output, and you're going to have a drop in blood pressure. So heart rates that are very fast decrease cardiac output because the ventricles don't have time to fill up with blood. Now, the heart can be not work properly because of mechanical problems with the heart itself, trauma to the heart, bruising of the heart if they impale their chest on the steering wheel if they're unbelted, squeezing forces during a crush or during an impact. But these mechanical problems, whether it be physical, squeezing, or cell death from a heart attack itself, and we'll spend quite a bit of time with heart attack when we get to that portion of the program. Mechanical problems and electrical problems, because the heart's an electrically driven muscular pump. And if the wiring diagram or the wiring harness of the heart malfunctions, you're going to get an irregular heartbeat, which could be significant enough to change cardiac output, lower blood pressure, and lead to shock. So mechanical and electrical problems can lead to shock as well. All right, we're going to end the session here with putting it all together as we discuss about the cardiopulmonary system, and then we'll pick it up again with shock. The entire cardiopulmonary system must work together in order for us to stay alive. We have to have an open airway. We have to be able to get air into our alveoli. There can't be anything separating the alveoli from the capillaries. We have to have good blood flow through the capillaries, bringing us the oxygen-poor blood and picking up fresh oxygen, and then being pumped to all parts of the body with a adequate pump, with a heart that's working adequately. There has to be a balance between ventilation and perfusion. And when we develop ventilation-perfusion mismatch, that's where we get into trouble. Ventilation-perfusion match is our respiratory rate is in line and at an adequate rate and depth to support the amount of blood flow that we have. Now, one of the more common places we're going to see problems with ventilation perfusion match and end up with something called ventilation perfusion mismatch is in patients who have large pulmonary emboli or large blood clots. In that particular case, they may be breathing normally, maybe perhaps even a little fast. They'll be breathing at an adequate rate, at an adequate depth. And when you listen to their lungs are going to be clear. So it isn't a ventilation issue that you can't get oxygen into the blood. It's a perfusion issue. You can't get oxygen into the blood because you don't have a good blood supply going through those capillaries because they're blocked with a clot. All right, so here's where we end this particular talk, and we'll pick it back up in a bit with shock. If you have any questions, you certainly know how to get a hold of me. Thanks.